Welcome to another lecture by Medico-Medics, Central Nervous System Pharmacology. In this lecture, we will begin with an overview of CNS pharmacology. We'll talk about drugs used to treat anxiety and sleep disorders, depression, and other mood disorders, psychosis, schizophrenia, epilepsy. We'll talk about drugs for neurodegenerative disorders, pain management, and as always, end with a summary. Now, CNS stands for the central nervous system, which includes the brain and spinal cord. So, CNS pharmacology is the study of how drugs interact with the system to affect things like mood, behavior, movement, and sensation. Now, these drugs can either enhance or dampen activity in certain parts of the brain or spinal cord, depending on the condition being treated. Now, most CNS drugs work by targeting a few key components. These are neurotransmitters, which are the chemical messengers that nerve cells use to communicate. We have receptors, of course, which are the proteins that these messengers bind to. We have ion channels that control the flow of charged particles in and out of neurons. And of course, enzymes that help synthesize or break down neurotransmitters. Now, CNS pharmacology plays a central role in treating a wide range of conditions, from psychiatric disorders like anxiety, depression, psychosis, to neurological conditions like epilepsy, chronic pain, and neurodegenerative diseases like Parkinson's, for example, or Alzheimer's. So, understanding how these drugs work at the molecular level helps us choose the right treatments and, of course, anticipate their side effects. Now, let's take a closer look at the drugs used for anxiety and sleep disorders. Now, these conditions often stem from overactivity in certain areas of the brain, especially circuits involved in stress response and arousal. Now, when these pathways are too active, patients may experience excessive worry, restlessness, or difficulty falling and staying asleep. To manage these symptoms, we use a few key classes of drugs. First up are Benzodiazepines, a classic group that works by enhancing the action of GABA, which is the brain's main inhibitory neurotransmitter. So by boosting or increasing GABA activity, these drugs, the benzodiazepines, help calm excessive neural firing. Examples here include diazepam and lorazepam, which are commonly used for acute anxiety and sometimes for muscle relaxation or seizures. Next, we have non-benzodiazepine sedatives, often called the Z drugs, like zolpidem. These also act on GABA receptors, but more selectively. The result is sedation with generally fewer side effects or dependence risks compared to traditional benzodiazepines. And they're mainly used for short-term treatment of insomnia, for example. Then we have SSRIs and SNRIs. Now, these are antidepressants that increase levels of serotonin and, in some cases, norepinephrine. While they take longer to work, these drugs are often used as first-line treatment for generalized anxiety disorders because they target the underlying neurotransmitter imbalance. Some common examples here are sertraline and venlafaxine. So, clinically, you might use diazepam to rapidly reduce acute anxiety symptoms, while something like zolpidem would be prescribed short-term to help a patient get restful sleep. So the choice, anyway, depends on symptom profile, duration, risk of dependence, etc. Now let's move on to pharmacologic treatment for depression and mood disorders. Now at the core of many mood disorders, especially major depressive disorder, is a deficiency in key neurotransmitters like serotonin, norepinephrine, and dopamine. Now, these chemicals are critical for regulating mood, motivation, and emotional stability. To address this, we have several classes of antidepressant medications, each aiming to increase the availability of these neurotransmitters in the brain. First-line drugs are SSRIs, which stands for selective serotonin reuptake inhibitors. And these work by blocking the reabsorption of serotonin into the presynaptic neuron. So if you look at the picture right here, you see the release of serotonin entering the synaptic cleft here. Now we have reuptake transporters. What the SSRI does is it blocks it. And when you block it, the serotonin is more readily available in the synaptic cleft for connecting with our postsynaptic receptors, essentially keeping more serotonin available in the synapse. Common examples include fluoxetine and escitalopram. They are generally well tolerated and are often the first choice for treatment. Next are SNRIs. These are serotonin norepinephrine reuptake inhibitors. These increase levels of both serotonin and norepinephrine, offering a broader effect on mood and energy. Typical example is venlafaxine, often used in both depression and anxiety. We also have tricyclic antidepressants, or TCAs, like amitriptyline. They also block the reuptake of serotonin and norepinephrine. However, they're older drugs and tend to have more side effects, such as anticholinergic effects and cardiac toxicity. So they're usually reserved for cases where newer drugs are not effective. Finally, we have the MAOIs or MAOs, the monoamine oxidase inhibitors. These drugs, like phenelzine, prevent the breakdown of monoamines, so serotonin, norepinephrine, and dopamine, by inhibiting the enzyme monoamine oxidase. Now, they can be very effective, but require strict dietary restrictions due to the risk of hypertensive crisis with certain food. Now, clinically, SSRIs are considered first line because they're effective and have the fewer side effects, especially when compared to TCAs and the monoamine oxidase inhibitors. However, the drug of choice, or the choice of drug, often depends, of course, or most often depends on the patient's history, tolerance for side effects, other comorbid conditions, etc. All of that has to be taken into account, of course. Now let's talk about the pharmacological treatment of psychosis and schizophrenia. Now, at the heart of schizophrenia and many psychotic disorders is dopamine overactivity, particularly in certain pathways of the brain, like the mesolimbic pathway. This excess dopamine signaling is thought to contribute to the symptoms we see, such as hallucinations, delusions, and disorganized thinking. So if we are dealing with dopamine overactivity, what do we do then? Well, to manage these symptoms caused by this, what we believe is the dopamine overactivity, we use antipsychotic medications, which primarily work by precisely blocking dopamine receptors, especially the D2 type or subtype. Now, we divide these drugs, the antipsychotic drugs, into two main categories. We have the typical antipsychotics like haloperidol. These are older drugs that work by mainly blocking D2 dopamine receptors. Now, they are effective especially for the positive symptoms of schizophrenia, like hallucinations, but they often come with significant side effects, including extrapyramidal symptoms, or EPS, such as tremors, rigidity, restlessness, etc. So that's the typical antipsychotic drugs, haloperidol. Then we have the atypical antipsychotics, like risperidone or olanzapine, and they are newer agents. Now, they block dopamine receptors as well, but they also affect serotonin receptors. Now, this broader mechanism seems to improve both positive and negative symptoms, and more importantly, it results in a lower risk of extrapyramidal side effects, like the ones associated with haloperidol, the typical antipsychotic. Now, clinically, atypical antipsychotics are preferred, especially for long-term management, because they strike a better balance between efficacy and tolerability. That said, they can come with their own set of challenges, of course. So we might have to deal with weight gain, or metabolic syndrome, or sedation. So individualizing treatment is utmost important here. Next, let's take a look at the pharmacological treatment of epilepsy. Now, epilepsy is a condition marked by abnormal electrical activity in the brain, which can lead to recurrent seizures. These seizures result from neurons firing in an uncontrolled, synchronized way, and our goal with treatment then is to reduce this excessive activity and restore balance. So we use several classes of anti-epileptic drugs, each targeting different parts of the neuronal firing process. Right? Because the seizures were a result of neurons firing uncontrollably. So we want to stop that. Now, first, we have the sodium channel blockers, like phenytoin or carbamazepine. These drugs work by stabilizing the neuron's membrane, specifically by blocking voltage-gated sodium channels. This makes it harder for neurons to fire repeatedly, which helps prevent seizure propagation. Next, we have the GABA enhancers like valproic acid and benzodiazepines such as diazepam. Now, since GABA is the brain's main inhibitory neurotransmitter, boosting its effect helps calm overactive neurons. Benzodiazepines are particularly useful in emergency settings for acute seizures, while valproic acid is often used as a broad-spectrum antiepileptic, effective in multiple seizure types. Then we have the calcium channel blockers. So we had the sodium channel blockers, right? Now we have the calcium channel blockers, such as ethoximide. I'm not sure about that, but let's go with that pronunciation. Now, these are especially effective for absence seizures. These drugs inhibit T-type calcium channels, particularly in the thalamus, which plays a key role in generating this seizure type. Now, clinically, valproic acid is a great example of a broad-spectrum agent, often chosen when patients experience more than one seizure type. such as generalized tonic-clonic and absence seizures. Now, let's wrap up by looking at drugs used to treat neurodegenerative disorders, specifically Parkinson's and Alzheimer's disease. Now, these conditions involve the gradual loss of neurons in specific areas of the brain, leading to a decline in movement, in memory, or cognition. So the goal of treatment is to manage symptoms and to slow progression, even though these diseases are currently not curable. So starting with Parkinson's disease. Now this condition, Parkinson's, is primarily caused by a loss of dopamine-producing neurons in the substantia nigra, a brain region involved in movement. So as dopamine levels drop, patients develop symptoms like tremor, rigidity, and slow movements. So to treat this, we use several types of drugs. We have levodopa, carbidopa, which is the cornerstone therapy. Now, levodopa is a precursor to dopamine that can cross the blood-brain barrier and then be converted into dopamine in the brain. So, dopamine itself cannot be given because it cannot cross into the brain. It will be blocked by the blood-brain barrier. However, its precursor form, levodopa, can. Now, carbidopa is added to prevent the breakdown of levodopa in the periphery, making the combination more effective and better tolerated. We have dopamine agonists like pramipexole, which directly stimulate dopamine receptors and can be useful in early stages or as add-on therapy. Further, just to enhance it even more, we have MAOB inhibitors such as selegiline. These work by blocking the enzyme that breaks down dopamine, again helping to prolong its action. So the disease, when we talk about Parkinson's, remember that it's primarily caused by a loss of dopamine-producing neurons. We want to counter it by increasing available dopamine. That's it. Now let's turn to Alzheimer's disease, which involves a deficiency in acetylcholine, along with the accumulation of amyloid plaques and neurofibrillary tangles. Now, treatment here focuses on boosting cholinergic signaling and protecting neurons. So we have acetylcholinesterase inhibitors like donepezil, which work by preventing the breakdown of acetylcholine, enhancing communication between remaining neurons. We have NMDA receptor antagonists such as memantine. These help regulate glutamate activity and protect neurons from excitotoxicity, which may slow down cognitive decline. So while these medications don't stop disease progression, they can help manage symptoms, of course, and improve quality of life for many patients. So let's finish with an overview of drugs used for pain management. Now, pain can be broadly classified into two main types of pain. We have nociceptive pain, which comes from tissue injury, like a cut, burn, or inflammation. We have neuropathic pain, which results from nerve damage, often described as a tingling or burning or shooting type of pain. Now, different drug classes are used depending on the type and severity of pain. First, we have opioids, such as morphine or oxycodone. These drugs work by binding to mu opioid receptors in the brain and spinal cord, effectively blocking the transmission of pain signals. Now, they're highly effective for moderate to severe pain, but they also come with serious risks, including tolerance, dependence, and addiction, especially with long-term use. Next are NSAIDs, or non-steroidal anti-inflammatory drugs like aspirin or ibuprofen. These work by blocking COX enzymes, which reduce the production of prostaglandins. These are key mediators of inflammation and pain. NSAIDs are particularly effective for nociceptive pain, especially when inflammation is involved. For neuropathic pain, we often turn to adjuvant medications such as gabapentin and pregabalin. These drugs were originally developed for epilepsy, but they also help reduce nerve pain by modulating calcium channels and dampening overactive nerve signals. Clinically, opioids remain some of the most powerful analgesics we have, but they're typically reserved for short-term or severe pain due to their high risk of addiction and tolerance. So non-opioid options are often preferred for long-term management when appropriate. So the key here is matching the right drug to the right type and cause of pain, but always balancing, of course, effectiveness with safety, seeing the bigger picture. So in summary then, some of the conditions treated with CNS pharmacology included, but is not limited to, anxiety disorder, depression, psychosis, epilepsy, neurodegenerative diseases, and pain. Some key drugs mentioned include benzodiazepines, SSRIs, SNRIs, antipsychotics, antiepileptics, and opioids. So, of course, CNS drugs are essential for managing mental health disorders, seizures, chronic pain, etc. And that's the end of Chapter 7. Continue now to Chapter 8. Thank you for listening.